March the 24th is World TB Day. In 2009, tuberculosis killed 1.7 million people. Despite this figure, the means to put an end to the epidemic, medicines, diagnostic tools and vaccines, remain inadequate or non-existent. Cambodia is a country particularly hard hit by the disease.
You're speaking of a disease that is impacting the life of tens and tens of thousands in Cambodia. So you're speaking about people that cannot go to school, that cannot learn, that cannot work, knowing that the poverty is very high in a country like Cambodia. You have about more than 30% of the population that is under the level of poverty. You can imagine the overall impact that is necessarily massive.
The most widely used technique for diagnosing TB is sputum smear microscopy. However, many cases go undetected using this method. Alternative tests exist, but they are slow and require sophisticated equipment that is rarely available. At Kampong Cham Hospital, in the heart of Cambodia, doctors are discussing the case of this young boy. He urgently needs to be put on treatment. But without a precise diagnosis, how do they know which drugs to prescribe?
Firstly, unlike adults, children don't produce many mycobacteria, and that means when they cough, it's very unlikely that you will find mycobacteria in any product that they can produce when they cough. Also in children, we tend to see more of what we call extrapulmonary disease, which means disease that occurs outside the lungs. And these forms of TB sometimes can be very difficult to diagnose because it largely relies on clinical history and a good clinical examination. There's no real test that you can do.
A new test offers hope for improvement in the testing of adults. It gives a reliable result for tuberculosis, including resistant forms of TB, in 2 hours, and it doesn't require a sophisticated laboratory. This means it can be used in district hospitals. Médecins Sans Frontières is set to introduce this test to 7 of its TB-related projects, notably in Cambodia. However, on the therapeutic front, the situation remains at a standstill, with drug resistance on the increase and as yet no new molecules. A young nation building its future. After 20 years of civil war in Sudan, the South voted in favour of independence. This summer, it will officially become the 54th African state. After 2 decades of conflict, South Sudan is faced with major challenges, including the lack of qualified medical staff and healthcare facilities.
First, there's the rainy season, which systematically leads to flooding and population displacement. Then, every year, there's malaria. And in April, so next month, the hunger gap period sets in, and the number of cases of malnutrition explodes. After that, as of July, we'll start seeing cholera.
With large numbers of southerners having returned from the north in recent months, there is increased pressure on health facilities in the region. More than 750,000 people live in northern Bahr el Ghazal state, and healthcare needs are considerable. However, there is only one general hospital in the state, and that's here in Awil. Médecins Sans Frontières has been working in northern Bahr el Ghazal since 1998. Teams are running paediatric, maternity and nutritional programs here, a decision made in response to alarming figures. For example, 1 woman in 2 dying following a caesarean section.
The maternity ward here does about 70 births a week, so it's pretty busy. Probably the biggest thing I've seen in the less than 2 weeks that I've been here is a lot of threatened abortions, incomplete abortions and stillbirth. That seems to be the majority of the problem that occur here.
Today, the team tended to Ewin, a young woman who lives an hour away from Awil Hospital. She arrived having already been in labour for several days. She had a caesarean section.
A girl? Yeah.
Like Ewin, 3,000 women gave birth in Awil Hospital in 2010. There are an estimated 2 million women in the world, mainly in Africa, living with obstetric fistula, an injury that disappeared from the Western world a long time ago. Fistula develops during complicated childbirth if appropriate medical care is not available.
They don't have the opportunity either to go to a hospital, to reach the hospital, or there is no hospital, or they don't have the money to go to the hospital and to pay the treatment. So they stay at home and they are in labor for hours and hours, for days. The child dies. Before the child dies, the pressure of the head into the pelvis reveals the fistula. If you have a pressure on the tissue all the time, there will be a necrosis and this will become a fistula.
Obstetric fistula is a hole in the birth canal. The consequences are twofold. It results in incontinence and social exclusion, as women often find themselves rejected by their husbands and communities. In Burundi, fistula is called the backyard disease. Yet fistula can be prevented and treated by improving access to obstetric care and by developing fistula repair surgery programs.
It's a wonderful feeling to give them, to heal the fistula and to give them a new life. If you see them coming and you see them leaving, different persons, you think you see different persons.
Médecins Sans Frontières works in 3 fistula treatment centres in Burundi, Nigeria and Chad. In more unstable regions, such as here in Democratic Republic of Congo, temporary facilities are set up for a couple of months next to a hospital, and large numbers of women are treated within that time. In 2010, these different interventional approaches enabled MSF to treat approximately 1,000 women with fistula injuries. At the end of December, long queues of people lined up in front of vaccination centres in Mali. Everybody aged between 1 and 29 was given the Menafrivac jab, the new vaccine that will protect them against meningitis for 10 years.
Si nous arrivons à atteindre les 95%.
If we reach 95% of the target population, epidemics could soon become a distant memory and we could put an end to the meningococcal meningitis A.
Mali is in Africa's meningitis belt, 25 sub-Saharan countries that are regularly affected by the disease. The previous vaccine only gave protection for 3 to 5 years. It wasn't worth vaccinating the population before an epidemic, as it's impossible to predict where or when an epidemic will strike. Teams had to wait for the first cases to appear before vaccinating. Menafrivac, however, provides immunity for 10 years. This means that vaccination campaigns can be organised in non-epidemic periods, as we know that vaccinated people will be protected during the next outbreak. The vaccine can also be used for children as of the age of 12 months. But above all, it reduces transmission of the bacteria, thus protecting the whole community, even those who have not been vaccinated. This might just mean an end to the fears triggered by every meningitis outbreak.
The village was very frightened of the disease. They were so frightened they sent patients to Kati, where they built special huts, which were guarded day and night so that the disease wouldn't spread. If you catch the disease, even if you get better, you can become deaf, mute, or paralyzed maybe. It can even cause death.
Médecins Sans Frontières teams participated in the vaccination campaigns in Mali and in Niger. A campaign was also organised in Burkina Faso. But of the 25 countries in the meningitis belt, 22 are still waiting for the vaccine.
The campaigns in Burkina Faso, Niger, and Mali were largely financed by donor agencies. But beyond these 3 countries, funding is still being discussed. Institutional donors have come forward, but there is not yet enough financial support to implement the campaign throughout the meningitis belt.
According to the World Health Organization, a further $570 million is required to vaccinate in all these countries, a sum it hopes to secure within 8 years. Strong commitment from institutional donors would help distance the threat of future epidemics. The banners said, "Don't trade away our lives, hands off our medicine." At the beginning of March, 3,000 people living with HIV from across Asia protested in the streets of New Delhi to defend their right to antiretroviral treatment.
It's a pity that we have to come out in the streets, travel such long distances, and really come out on the streets at this time of in the 21st century. In that sense, in 2011 we have to hit the streets to demand for treatment or to demand for life, our right to live.
It's generic medicines that are at stake. AIDS drugs in particular, but medicines for other illnesses like tuberculosis and malaria too. India is the world's largest producer of low-cost generic medicines, which are used extensively in developing countries. Negotiations currently taking place with the European Union could restrict access to these life-saving medicines.
The context of this free trade agreement has not been publicly disclosed. In this agreement, the generic medicines, the medicines produced in India for HIV and cancer patients at cheaper rates, will somehow stop being manufactured. It's to support this cause that everyone living with HIV and their supporters have assembled to protest and to reach out to the Indian government, media and parliament so that they at least think twice before they make any significant decisions.
Intellectual property provisions in the free trade agreement, particularly the data exclusivity measure, would prevent Indian manufacturers from producing generic medicines from molecules that are already off patent or from molecules that don't even merit one. Millions of sick people in developing countries fear they will no longer have access to treatment, turning the clock back 10 years.